Up next is Dr. David Hay, product strategist for Orion Health. David is known to many of us through the international standards work he's done, Chair Emeritus from HL7 New Zealand, co-chair of the HL7 FHIR Management Group, participating in numerous New Zealand health information standards organizations and advisory groups. I've read his FHIR blog. I use it actually when I'm trying to understand certain things about Smart on FHIR, and also FHIR, a set of open source tools to help clinicians sort of get engaged and start using FHIR. And so with that, I'm going to pass it over to David Hay.
Thank you very much. Okay, well, thank you very much for inviting me to come along here. I think I'm going to go for the prize for the person who's come the longest way to get here. So I started in New Zealand, and I flew to San Francisco, and then I flew to Toronto, and then I went to Newfoundland. That was yesterday. Then I came back to Toronto, and I came here. So I reckon I've got the miles. So my talk today is really more about the basics of FHIR, and particularly focused on, I guess, clinicians and business analysts. So just a show of hands in the room, who here would regard themselves as either a clinician or a business analyst or something like that? Brilliant. Okay, well, this is for you. Just a bit about me. I'm a medical doctor, as was being said. I think most of this has already been done. I work at Orion Health. I'd like to thank Orion for flying me out here, even though they did make me work for the privilege. So my goal here today really is, assuming that you don't know a heck of a lot about FHIR, to understand what the basics are of FHIR, and ideally to make you want to find out a bit more about it, and to try and do that inside of 30 minutes. This is hard. I'm going to give it my best shot, and hopefully I'll leave room at the end for questions. So just a question on what is FHIR. Well, obviously FHIR is an interoperability standard intended for sharing clinical and administrative information. And I like to say that there's actually two main parts to FHIR. So the first part is the content model. The first part is the bits of information that you want to move around. And the second part is the exchange standards. Now, one of the things we haven't done particularly well in the past as HL7 is to talk about how you should actually package and move information around. This is one of the big things that FHIR adds to us. And although I said that there are two main parts, there's another third part which is equally, if not more important, and that is the community that's been built up around it. And really, Graham Grieve, who's a sort of father of FHIR, he hates being called the father of FHIR, by the way, so please don't tell him that I said that. But he calls FHIR a treasure. And I think he's actually right, because I think it goes a long way more than just a simple set of standards. These are people, this is a community of people who want to share information, and more importantly, who want to help each other do it. And that's really the coolest thing about FHIR. So if you take nothing else away from my talk, then that's probably what I would like you to take. I thought it would be useful to say, where is FHIR going? So where do we think that FHIR is heading from this point? Unfortunately, I've only just arrived here, so I've only seen the last couple of talks, but there's obviously a lot of activity that's going on in Canada at the moment, which is really neat. So I think in terms of where we're moving to next, the first is more resources. We've got about 120, 130 or so of them at the moment. We figure on about 160, 170 all up. So we're going to be working on more resources to cover up more parts of the healthcare domain. More resources are going to start moving to a normative status, and again, the previous speaker talked to that. So we're going to see some of the more commonly used resources become normative. We're moving beyond interoperability. This is, again, one of the key things. So FHIR started out, FHIR stands for Fast Healthcare Interoperability Resources. You very likely knew that. But we're moving way beyond that. And in particular, we're moving into the areas of clinical decision support. And we've got concurrent sessions going on here in CDS hooks, which is the standard I'll talk to towards the end. And quality measures as well. We're also seeing FHIR being used for persistence. Again, this is not what we expected, and we're pretty emphatic about the fact that to use FHIR, you don't actually need to store it as FHIR resources, but people are doing it, and that's really interesting to us. We're not really quite sure why that is the case. We like to think that it means that it's obviously fit for purpose to do that, but it's an interesting and somewhat unexpected development. And we're seeing the growth of associated standards around FHIR, standards that maybe started out separately to FHIR but became part of FHIR. And SMART and CDS hooks are two of the ones that obviously spring to mind. And again, I'll touch on those a little bit later on on in my talk. And then finally, accelerating implementations. You know, a year or so ago, I would have been standing here to you today saying, FHIR is really cool, you should do something with FHIR, it's really useful. These days, people are doing that. There's only one place on this planet where there isn't a FHIR implementation, and that's Antarctica. So if anybody lives in Antarctica, anyone live in Antarctica? No, okay, all right. If you do go there, and if you do have an implementation, please let us know, because I'd like to fill in that gap. Any Star Trek fans in the audience here? Excellent, so you understand the Borg. You know, okay, so we're not going to sort of put nasty things in your eyes or anything like that, but in the same way that the Borg kind of assimilate things, FHIR's kind of done that as well, and you've seen it, haven't you? I saw this on there and I thought, we are the Canadian Borg. Resistance is impolite. And I thought that was great, you know, isn't that just wonderful? It's not futile, it's impolite, okay, that's even worse. And I've been told that the French down there is correct, so I thought that was appropriate for this audience. I'm a techie, okay, so I actually have at home a hat that has a propeller on it. You know, way, way back through there. I spin it and nothing happens, but I have it. So I think it's a good idea to sort of perhaps stand up a bit from the technology and think about what are the benefits of FHIR. Why are we doing this and to whom? And I call out 4 audiences here. So for a clinician, I think the biggest area of benefit, the biggest way that FHIR helps out is that it will help you become involved in system design. And it's all recognised, we're well recognised that projects that are led by clinicians have very heavy clinical input are much greater to succeed as lowers the barrier to understanding so that clinical folk can become more involved and can more direct clinical projects. And of course they're also going to get benefit by the fact that they're going to get access to clinical data which they might not otherwise get, and of a higher quality. And again, previous speakers have talked to the fact that FHIR gives us the ability to get structured and coded which we simply don't get out of documents. Consumers or patients, again, they're going to get a similar kind of benefit to the clinicians do in the fact that they're going to get access to data, and they can call up a mobile app, look at what the doctor reckons their medications are and compare it to what they're actually taking themselves. We're going to get a quality feedback there which is going to have a tremendous impact both on the quality and the safety of healthcare delivery. And it's really FHIR that's underpinning the ability to do that because it's underpinning the ability to create these innovative applications. And speaking of innovation, I think if you're a healthcare organisation, if you're a hospital or something like that, FHIR will give you the ability to innovate because it opens up your data. Currently, the data sits inside of large enterprise systems. The user interface that you get is the one that the enterprise vendor gives you. You can't move outside of that. But as these vendors move more and more towards FHIR, and they absolutely are, you're going to have the ability to create or get created applications that specifically suit your business needs. And that's going to open up a whole lot of different possibilities. And then finally, as a vendor, the huge value of FHIR to me as a vendor is that it's familiar. It uses familiar technologies, it uses these development environments I'm already used to, I don't have to learn stuff new, and we are seeing the concept of the app marketplace. And again, this is a comment that a few people have already made. Exchange paradigms. We like to think, well, at least in the FHIR community, we think of a number of different ways of exchanging information. And I think we've probably all always known this, but this sort of FHIR kind of brings it out and brings it front and centre. So the first one is the RESTful interface, where REST is sort of like a real-time interface, representational state transfer for the geeks in the audience. This is the real-time access. This is what was required. This was actually what drove FHIR, and I think you probably all know about the Jason report, which came out in the US, which called out the lack of an API, and of course the Argonauts came along to slay Jason. I mean, who says that geeks don't have a sense of humour? I mean, isn't that just so funny? Or not, as the case may be. So the RESTful paradigm is a real-time exchange of data. Services kind of take RESTful to the next sort of level. You still have a simple interface, but you hide that complexity behind the simple interface. Messages, of course, where you have a system who has done something and wants to notify somebody else or wants to ask them to do something, and then once that thing has happened, the message itself can be discarded for other than audit purposes. And then finally, documents. And of course, messages is the version 2, HL7 version 2 or version 3 messaging. And then documents, which are a summary at a point in time. They're part of the clinical record. They're a discharge summary, a progress note, or an operative record or something like that. So they're sort of the exchange paradigms. And FHIR covers them all. And so what we can see in a FHIR-based infrastructure is you could imagine that you're getting different information, or similar information, I should say, from different sources. So maybe a lab result as an observation in that top left-hand corner there. And then down the bottom there, you've got a clinician's notepad device taking maybe blood pressure readings or recording temperatures or things like that, store them in a FHIR repository and then bundle them up into a FHIR document. And with a FHIR-based ecosystem, you can do all of this with exactly the same resources. You don't have to map between different representations of the same concept. They're the same resources that go into all of those things. And of course, it works back the other way as well. You can get a FHIR document, and because the FHIR document already contains the resources, you can pull them out and put them into your repository. With CDA, we said you could do that. You know, anyone who's tried to do that with CDA knows that that ain't necessarily so. So we're going to see huge value in this way with FHIR. Here is just a picture which calls out some of the areas that you might want to use FHIR. So to the left-hand side there is, I guess, the traditional way, where you've got data in a repository of some sort, and you have a library that interfaces and then produces FHIR on the outside. And one of the great things about the community is that it's produced and made freely available, open source available tooling to do that API library bit. So the Happy library from that very clever James Agnew chap here is one which is very widely used. It's the one that we use inside of Orion, and it's used elsewhere. But this makes it a heck of a lot easier to become part of the FHIR community than if we'd had to do it all of ourselves. The middle one there is where you're actually storing the FHIR resources as resources in your persistence layer. Again, we didn't expect that people would do this. We're finding that it's happening more and more, which is really quite interesting. And then over on the right-hand side there is the concept of the integration engine, because again, you know, FHIR is great and wonderful, but it's going to take a while to come into play. And so brings me to this slide here, which sort of talks about where FHIR sits in the family of FHIR standards. By the way, I'm talking a heck of a lot faster than I normally talk, just in case you were wondering, because I do want to get through these slides. So FHIR, so HL7 has got a number of interoperability standards. The first one is version 2, which is a messaging-based standard. It's been around since about 1987, grew out of Duke University in the US, as you probably know. Next, it's been there since 87. Version 3 came along, and again, you guys know a lot more about version 3 than I do, but the idea, of course, in version 3 was to shift from the idea of having sort of each implementation doing their own thing to having a common model, which if we all map to that model, then we'd get greater semantic interoperability. Didn't quite work out as well as we might have hoped. CDA, a member of the V3 family, has succeeded very well, and I think part of the reason for that is that it created the ability to be able to share information at a textual level and then to improve it gradually, bringing in structured data and coded data. So CDA has certainly been a big success. And finally, we have FHIR. FHIR is really only about 6 or 7 years old, so we're really the new kid on the block. And really, I guess, what I kind of like to say to in this particular slide is that these other standards are going to be around for a long time. Version 2 in particular, even though FHIR can theoretically do messaging, and it's being used in some areas for messaging, the reality is that version 2 is going to be there for a long time because it works and because there's a huge infrastructure that's in place. Version 3, perhaps slightly less so. It was picked up, as you know, in Canada, of course, and in the UK, but less so elsewhere. I think the expectation is that we're gradually going to see a replacement by FHIR in that space, although again it will take time, because when you've spent a lot of money and you've built a large infrastructure, you certainly aren't going to get rid of it overnight. So we need to be thinking of strategies as to how we incrementally move away from there. CDA, Again, this is an interesting one. There's quite a lot of CDA that's in use. FHIR documents are getting a lot of press at the moment. There's a very active project inside of HL7 which is mapping between CDA and FHIR, and the intention is that the FHIR project will actually provide you with, or provide the community with mappings between CDA, CCDA in particular, and FHIR. So it's going to be interesting to see what happens with CDA. My guess is that we will see a relatively rapid replacement of CDA. I'm talking 3 to 5 years worth of relatively rapid, but nevertheless, FHIR does give us significant advantages there. So what's different about FHIR? I'm well aware of the fact that we standards geeks periodically stand up here with the greatest, latest and best kind of standard. Back at home, I was talking to a colleague in a lab system, and I said to him, Graham, this is, different Graham, you know, FHIR is great, you really need to get into FHIR. And he said, well, Dave, you know, 3 years ago you were here telling me how great CDA was, and now you've come back. And that was a wee bit embarrassing. So I thought it might be useful to say what's different about FHIR. Why do we think this time around FHIR really is the next big thing? So the first thing is it's designed for implementers. We have unashamedly gone back to the idea that we need to focus our efforts as standards organisations. We need to focus our efforts on the people who are shifting information around. And we have a bit of a saying in the FHIR community is that if it doesn't make an implementer's life easier, then it really doesn't make it into the spec. It uses familiar technologies and standards. This can't be overstated because it makes it so much easier for people to get involved in FHIR in the first place. And if any of you have actually had to develop say a V2-based solution, you'll be aware that there's actually a big learning curve to understand how V2 actually works. What exactly are segments? You know, how do all the things fit together? Why can't I have a carriage return line feed on the end of my line sort of thing? V3 it's XML, that's great, but gee, it's not easy XML. So there's quite a barrier to new people coming in, and we need to encourage new people to come into our communities. And it uses familiar security standards like OpenID, like OAuth 2 and such like, which I'll touch on in just a second. The community has been involved in the beginning, and again you can see I'm coming back to this point and again and again and again. It's actually about the community as much as it is about the standard. And that community is not just a community of standards geeks, it's a community of implementers, and it's particularly a community of clinicians. And some of the tooling which I'm responsible for developing, ClinFire, was developed because the clinical folk in HL7 needed a way to understand and interact with the standard other than by using XML and JSON objects. So we saw from very early days the clinical folk, the business users becoming involved in the development. There's a load of support for FHIR out there. There is the online chat where you can get an answer within minutes usually of asking the question. People like Graham and your own Lloyd Mackenzie are so active on there, you know, you sort of really wonder whether they're actually human or whether they're actually cyborgs. I mean, maybe that Borg picture I had before was closer than I thought it was. But there's an awful amount of support. There's test services. There's lots of examples of what a resource should look like. There's tooling, there's blogs, there's a community chat. So it's very, very easy to ask a question and get an answer. We use connectathons extensively where we actually test out how the specification actually works. It's open source, it's freely available, and it's already widely implemented. You know, we've only been going about 5 to 6 years, and already we have implementations around the place. That's where the specification sits. I'm going to flip past that slide, hl7.org. Big thing though is it's there and available on the net. You can run to it straight away. Again, you could not do that with the previous standards, and it's fully hyperlinked. You just click down to what you want to see. I suspect that most of you know what resources are already, so I might just flip past this reasonably quickly. But I will touch and just bring out a couple of the major points. The resources is the content model. It's the thing that you're moving around. So if you're imagining you're building something with Lego blocks, it's the Lego block. And it's been built by a whole lot. It's built on the top of existing stuff. We didn't just sit down and think, oh gee, this is fun, let's do something. We took what was already there and we tried to improve on that. And that's not just inside of HL7. That includes other standards development organisations such as FHIR and CIMI and ISO 13606 and all that kind of stuff. And here are some resources. Again, very likely you're familiar with these. There's two things I call out when I show this slide. The first is that every resource has got a name, and that name means something. So when you see a resource that says procedure, you've got a good idea what it actually is. And conversely, if you're looking for a resource for, say, an immunisation or a medication, it's pretty straightforward to find it. Again, all of this part of making it easy to find and easy to use, especially for those who aren't familiar with our rather complicated domain. We've talked about STU and normative and such like before, but I just want to again emphasise the fact that we have a slightly different approach for FHIR in that we have what we call a maturity model. So individual resources have a level of maturity. It's based on CMM and it's a number between 1 and 5 and then on to normative. And the higher the number, the more practiced that resource is. And we have various rules. There's a properly laid out page as to how it actually works. But a resource is not going to become normative until people have proved that it's fit for purpose. And that's, again, a key takeaway. Here is another really key takeaway. A single resource in and of itself is useless. It's only when you combine it with others that you can tell that clinical story. And here we have the example of a procedure. And the procedure up to the top there has a subject, which is a patient. To the bottom right, it was performed by a practitioner and so forth. So a way to conceptualise this is that you tell a clinical story in a graph of interreferencing resources. And that graph can grow and become large. And it's this interrelationship, which is a lot of the power. We were talking about bulk downloads before, for example. So that helps you understand the relations between the different parts of health information. Structured and coded data. Why have structured data in the first place? Well, the main reason is that we have structured and coded data, then we are able to do other useful things with it. Particularly, we can do a number of things. We can display it in a more sensible way to a clinician or to a patient, or consumer, I should say. Sorry, an ex-medical thing that gives me troubles. And we can also do secondary things. We can do decision support on it. We can do analytics on it. We can do population health. We can do reporting. So having structured and coded data is really critical to this whole concept of semantic interoperability. This is a structure picture of what a resource looks like. If you again, I'm not going to go into great details in half an hour. I really don't have the time to do so. But the bits I would like to call out are the fact that it's very easy to see. It's fully hyperlinked. Every element has got a particular data type that you can drill down to. Some elements, the ones with the X on them, can have more than one data type. And that's possibly all I'm going to say about that slide. Maybe one other thing I will say is that when you first look at a resource, the first thing you're going to say is this resource is incomplete. You know, it's missing something. Patient does not have religion. Patient does not have ethnicity. Patient does not have race and so forth. That's deliberate, and I'm going to come back to that point in a minute. Terminology. You could spend entire lectures on terminologies, and I don't propose to do so here. FHIR itself is not a terminology. FHIR works with terminologies such as SNOMED and LOINC, ICD and so forth. Again, I don't have the time to go through this in detail, but the things I do want to call out is the importance of that value set in the top middle. So the value set is the link, if you like, between what information you expect in a particular resource element and the code system from which it comes. If it's a condition resource, for example, what should the code of that be? Which code system should it come from? It's very, very flexible, very, very powerful. Profiling. Now, I mentioned before that when you look at a resource, you're going to look at it and you're going to say there's stuff missing. So what profiling is about, we took a very deliberate step when FHIR was being developed, and that was that the core resources were only ever going to contain that information which most people were already moving around, and we would have an extensibility methodology to add the extra things in that a particular domain needed, because this was recognising the fact that different jurisdictions, different countries, different realms have got different requirements, and we didn't want to bloat our resources out. So profiling is all about taking those base resources, taking away the bits that you don't want, adding in the bits that you need and which aren't there. And the three main aspects to profiling: constraining a resource, taking something out; changing the binding, putting a different value set. So marital status in New Zealand probably has a different set of code to marital status in Canada, and then adding in a new element. So profiling is very much a statement of use, and the previous speaker was telling a lot about what profiles actually are. Profiling is a really important part of where FHIR is actually going. So here's just an example there of the sort of things that you might do with the resource in terms of, you might want to limit a name to just a single name, you want to change the marital status, as I said before, identifiers, add accessions, and so forth. So FHIR is about making it work. An implementation guide is what wraps everything up into a single coherent whole. There's profile tools that we've talked about before. Simplifier and Forge are great tools. I will just very quickly call out ClinFHIR as being a tool that you might use as an educational tool, but certainly Forge and Simplifier are the main system divide tools. There's a bit of a sweet spot, I believe, where something like ClinFHIR can help with learning, but use your main tools for your main artifacts. Connectathon, I might flip past this, but Connectathons, you're doing a Connectathon here, so I assume that you know what they are. A key part of FHIR, because it's how we make sure that it's actually fit for use. This was the New Orleans Connectathon. We had 240 people attending that Connectathon. I'm the one in the middle with the Connectathon mask. I'm the only one, with a New Orleans mask, right, because it was Mardi Gras. I was the only one for some reason, don't know why. Security and privacy, FHIR is not a security standard. I like to say FHIR doesn't do security, but that's of course not true. But the key part here is that FHIR recognises that security is complex and it's done differently in different domains. We support security and privacy, of course. All resources have got tags that you can apply to them. We have specific resources such as audit event and provenance and so forth. We're not sure about blockchain, but you can't really give a tech talk these days about blockchain, so I stuck it in there. We don't quite know where blockchain is going to be, except that blockchain is not for storing the clinical record. It may be for things around it and for change responsibilities, but it's not there. I am getting towards the end. But I did want to call out two things. SMART, which is really a security standard. It's a profile against OAuth, is the quickest and the easiest way to think about it. So in the same way as you can set up external authorization servers such as Facebook and such like, as we can do the same sort of thing. It grew out of the desire to support an app marketplace. And how can you securely allow apps developed by other vendors to access EHR data? And it kind of grew on from there. This is a really cool picture that I drew. I'm really, really proud of it, and I don't have any time to show it to you, which is a great tragedy. But it's there for when you look at it later on. It shows how the bits actually hook together. Scope negotiation, this is actually kind of an important part of FHIR. So important part of SMART. So what this is doing is this is allowing an application to ask an EHR to access certain resources and for the EHR to come back and say yes or no, you can't have them. And I call it a negotiation because it's quite feasible for an application to ask for data that that application or the user of that application doesn't have access to. So it is a negotiation. The app will not necessarily get what it asks for. That's up to the data source. Blue Button and Sync for Science are things that you are going to hear about. They are basically specific, almost projects using SMART. So Blue Button, and the first speaker this afternoon talked to that. That's getting US claims data out, again using a SMART/FHIR interface. Sync for Science is another one you'll come across. That's all about the ability for a person to allow researchers to share their data. But fundamentally, both of these projects are the same sort of thing. They're giving an individual control over their data and access to their data, potentially to other people. And we will see more in the space, I am quite sure. CDS hooks, given that there's a whole section on CDS hooks, is not one I need to spend a lot of time on. It's important, though. What it is it separates the provision of decision support services from the invocation of decision support services. It allows for separate organisations to set themselves up with a decision support service and then have other systems use that. So we're going to see specialist services being created. And the big thing about this is it can be configured so it all happens behind the scenes. So the clinician doesn't know that it happens, they will just get advice as and when they need it. and I do believe reality check. Okay, sounds wonderful. We are realising that we need to cut the height back just a little bit. I'm building a house back in New Zealand there, and I think the analogy of FHIR is that this is all about the concept plan. We still have to take that concept plan and build something with it. And healthcare is hard. So what does FHIR really stand for? That's what FHIR really stands for. Thank you very much. I do think I have a couple of minutes if there are any questions. Okay.
So, David, maybe putting on your New Zealand hat on, can you tell us a little bit around what's going on there from like a national perspective or at a local perspective to try and establish FHIR profiles, kind of standardize it so it's less hard in real life? Just for context, you know, we had Steve from the ONC speaking, we had panels from some of the European folks, we had Attila from Canada Health Infoway, and so very much interested to hear what's going on in New Zealand.
I'd like to take the fifth on that. Sorry, this came up in news recently, not quite sure why. But it's slightly embarrassing. We actually aren't doing all that much as we should be in FHIR at the moment. Part of the problem is that New Zealand is a smallish kind of country. We've got a very large project going on in healthcare at the moment, setting up a national system, and that's kind of soaking up all the interest. So I'm slightly embarrassed to admit that in New Zealand, we are a wee bit behind everybody else. What that actually means is a huge advantage is that you guys are going to make all the mistakes, we're going to learn from those mistakes, we're going to leapfrog. Just you wait, I'll be back next year. Thank you very much.